Good morning, everyone, or the afternoon, depending on where you are. I'm Russ Glasgow, and I'm delighted to do this first introduction to the TIDERX series, which I am sure you're going to find an incredible educational experience, and congratulations to all of you for being selected. As you can see at the bottom, this is an amalgamation of prior work and slides from a variety of people. So if there's anything you like in here, it's probably due to somebody besides myself. What we're going to cover today are four things, and I am going to go quickly, but the good news is you have some great readings to accompany this that you can refer to. So the first thing I'm going to do is convey to you both the need for and the urgency for D&I research. Secondly, I will go quickly, but over some important fundamental terms, and particularly similarities and differences that people frequently conflate different terms. Third, and maybe the most important, cover key concepts and how this can inform your work and how D&I is different than other types of health research. And then finally, I want to leave you with instilling some of the excitement and the opportunities for D&I research as we go forward. So to begin with, some of you may have heard the phrase about 17 years for research to turn into practice. Well, this is a kind of classic slide from Baylis and Boren publication, but it has been replicated by others, showing why that is and how long it takes. And many of these things, it's even worse than this because this starts with once the research is funded. So it doesn't involve the several times of resubmissions and time lost there, but you can see how it takes through getting a publication accepted, getting somewhere in, getting picked up by a systematic review, and what happens. And I think my slide is supposed to advance here to give you the bottom line, but I'll tell you in case it doesn't come up automatically, is that most people know the phrase, it takes 17 years. What they don't know is that it takes 17 years for 14% of the original research. So 86% of the original research, nothing happens at all. It just sits on the proverbial bookshelf. So why do we need pragmatic and D&I research? The whole host of reasons, you're probably familiar with many of them, but it is to translate things into the real world. As Larry Green says, one of my favorite quotes, we want more evidence-based practice, we need more practice-based evidence. The last point there, a classic article by Rothwell documents that the most common reason that practitioners don't adopt evidence-based medicine is they don't see the research as relevant to their setting, feasible or applicable in their setting. I'm going to turn in a moment to a definition of some of the terms, but as you can see from this slide of overlapping ovals, kind of a Venn diagram that I've adapted from the Mitchell and Chambers article that you have, shows the intersection of all of these terms, which are kind of highly related but slightly distinct. And I'm going to quickly go over some of the nuances, and then I'll leave it for your in-person facilitators or online if you have follow-up questions. The last thing I started with is the dotted lines. I added that on pragmatic research because I'm going to go over that. But the point is here is there is a lot of overlap but some differences between dissemination research, implementation research, what we're now calling quality improvement science, which as you can see is related to QI, and probably I maybe even should have had the oval overlap with that. But don't worry about the details, but I just want you to get the concept there of how these things are interrelated. So let me drill down on this and kind of differentiating implementation science from dissemination research from pragmatic research. And again, these are permeable barriers between these. These aren't black and white issues. So the overall issue of what we're doing is we're looking at the integration, or some people say translation, of research into practice. Policy and practice, I should say, important to add that. More specifically, underneath dissemination, D&I research, dissemination research is the study of the targeted distribution of information, and you can read the rest. I want to differentiate the science or the research here from just the act of doing dissemination, which is not the study, but it's just the doing of it. Implementation research, slightly nuanced, different, is the use of strategies to adopt and integrate evidence-based intervention into practice. And finally, where I'm going to start with, and a lot of people don't add this in or differentiate, is pragmatic research, which has also seen a big influx both within D&I and with other types of more traditional health services research as real-world tests in real-world populations and settings. So this difficult-to-view slide, but one that I find helpful, comes from a paper that David Chambers and I did, talking about the characteristics of D&I research, and many of which are in contrast to traditional research. I won't read all of those to you, but some key issues are, we like to say context is critical and often kind of overrides everything else. The D&I research is definitely multi-level. It focuses on generalizability and representativeness. It focuses on the tough goal of scalability and sustainability. That's an aspirational goal. It is rigorous, but in an additional way from traditional research. Points 9 and 10, again, are maybe aspirational, but where I think we're moving and where the field needs to go even more to be rapid and adaptive. And with that, given the time, I'm going to go on. The old field of dreams analogy is true. As I'll illustrate in a moment, we've too often assumed that if we provide the evidence and we create a great program that we and our colleagues like, and maybe even is published in the premier journal of JAMA or American Journal of Public Health, then that everything will follow and people are surprised when it doesn't. So a quick hypothetical story, but one that's an understatement of the issue or situation, is assume for a moment that we had an incredible effective intervention, be it precision medicine or be it a public health campaign for, well, whatever, cancer screening that was 100% effective, 100%. But then think about, this is the breakthrough science. This science then has to be, one, adopted, particularly adopted by representative settings and that deal with highly marginalized populations. We have to have practitioners trained in how to do it, and not everybody is an early adopter. These practitioners have to choose to deliver it, often in the face of many competing demands. Populations have to be trusting and available and have the resources and be willing to do it. And then it has to be sustained. So if you assume, and this again is an over-generous estimate, that 50% for each of these steps were done, you could look at the putative impact at the bottom of 0.5 times 0.5, and so what you end up with, instead of 100% effectiveness, you end up with 3% benefit. And I wish I had more time to talk with you about this and the implications, and if you were in person, I'd ask you about the moral of this story, but let's just go on. And I'll show you, this is at least compatible with, and something I use to illustrate the use of our REAIM framework, the acronym for which you can see there. But the notion here is to focus on these sequential steps of getting evidence into practice that talks about issues such as who's intended to benefit, and then who actually participates, what's their representativeness, and then importantly, and I'll talk a little bit later on, using a mixed methods approach, how and why do people participate or not participate? And you can see the other elements of our REAIM dimension there, but again, related to that hypothetical multiplication example there. So slightly changing venue here or topics. How well do research and practice, or I would also say here's important, policy connect? And these next series of slides are adapted with permission from Ross Brownson. So in terms of looking at what do real-world practitioners, here Ross has used public health agencies on the left, and then contrasting that with researchers on the right, what is their kind of worldviews, or how do they get the evidence out? How do they think? What do they need information to have successful dissemination? Well, the bottom line here you can see is that in terms of rank order, practitioners rely on professional associations that they trust, workshops and seminars, increasingly social media. These data are a few years old. And finally, at the bottom, journal articles. Contrast the right-hand column. Most of us still believe, because of our training, that if we publish a great article in a great journal, you know, magic will happen, the field of dreams things there. So what do we know about dissemination per se, and findings from dissemination research? Several points there. I'll just focus on the ones in blue or that are highlighted. And we know that more passive approaches or diffusion, just assuming things will naturally take place, are usually, I do highlight usually, ineffective. There are some circumstances, and you might think, for example, of a new pharmacological intervention that where there's a lot of millions and millions of dollars of advertising and outreach and training and how to use it and that sort of thing. But generally, it doesn't work. We do know, as Picori and others have told us, that stakeholder, and I would say multi-level stakeholder involvement is really a critical aspect of successful dissemination. But one size doesn't fit all. It needs to be tailored to fit different situations. Now I'm going to turn and talk for a moment about the practice rather than the science. It's what have we learned from the science about how to disseminate or scale up, or as Greg Ahrens and colleagues recently made a useful distinction, scaling out, going to different settings. So what we mean by designing for dissemination, and many of us like to say it's never too early to begin designing or planning for dissemination, is trying to ensure the best you can that evidence-based interventions are developed from the outset in ways that are going to align with the adopting setting and the individuals within that. It's going to meet their values, preferences, resources, availability. And with that, I'll go to the next slide. So again, it's never too early to begin early. I think, very nice demonstration example of this kind of four-element approach that, again, Brownson and colleagues have come up with, talking about the structures, the process that you have, the products that you have, and systems changes that are necessary. And all of these things need to fit together. The intervention needs to fit the context, and the implementation strategies need to be appropriate and tailored to your target audience. So one fairly recent thing that your NCI colleagues and hosts are going to explain to you is the new SPRINT program, Speeding Research-Tested Interventions into Practice, which is a way to get things out. It integrates a lot of work that's done in terms of commercialization or tech transfer with the principles and the things that I've just gone over. There's a separate training on this that I'll let others explain to you. Now I want to turn, again briefly, and talk about the notion of theories, models, and frameworks in D&I. There are both a huge number. Now there are well over 100. The classic article by Tabak et al. Is referenced at the bottom there, and they, let's see, I think that was 2012, had 61 frameworks and models that they talked about. And this is often a really confusing thing for people getting started. They're kind of overwhelmed and they say, well, how can I ever make sense or know what works here? I like to focus on the commonalities and then some guidance for what works specifically in your particular situation. But here's the commonalities, is that context, again, is critical. There's an important need for focus on external validity and engaged stakeholders. And importantly, and something that I'm pretty sure you'll go into later, are readings on this critically important issue of the balance between fidelity or consistency and internal validity of delivery of a program and implementation strategy with adaptation and appropriate adaptation to the local setting. Critically important, much easier said than done, but that's an evolving and important area there. So thinking about using theory to choose an implementation framework. So this is kind of the how. You've got the what in terms of your evidence-based intervention, but how are you now going to get this into broad practice? Frameworks can be used for that too, and people like to, particularly Ann Sales has been a leader in this area, made a distinction between explanatory and process frameworks. Said slightly different, the explanatory processes are more like traditional theory, for those of you that have a background in behavioral science, and many of them honestly come from an individual focused, particularly psychology, like the theoretical domains framework. Others, like the RE-AIM framework that my colleagues and I work with, and a number of others, including Getting to Outcomes, are more directive or applied. They're less conceptual or they are not formal theories. So here's just one quick example of an elaboration of our RE-AIM that shows at the top contextual factors. It calls out specific contextual factors, things like, just briefly mentioned on the left, the implementation and sustainability infrastructure, and then the fit or match between an intervention and the recipients, and how those work to then inform the RE-AIM outcomes at the bottom. I will strongly refer you to what I think is a really incredible online resource or website that Borsika Rabin and colleagues have developed that's simply called disseminationimplementation.org, which reviews the articles. I think we now have 76 or 79 online and described and characterized, and we're hoping to expand those in the number in the near future. But this website not only guides you through selecting, depending on what the characteristics are in your setting, but also will provide some guidance on adapting frameworks, because often no one framework works exactly as it was proposed. How you can integrate different frameworks. Often we need to combine two or more frameworks that are compatible, and then maybe even more of a need for research is it helps you link through another MCI resource called Grid Enabled Measures website, links the theories and the constructs to particular measures. So if you can't tell, this is one of my soapbox things I like to push pretty hard, so I'll try not to go on and on about that. Coming back to this basic point, frameworks inform implementation strategies, and those are usually multi-level. Here's a quick example of one of the more straightforward models or frameworks, the Replicating Effective Programs, or REP frameworks, that Amy Kilborn and her colleagues developed in collaboration with the CDC. And you can see, again, the different steps, and underneath each of the steps, in pre-implementation, implementation, then broad-scale dissemination or spread, what are some of the key issues guided by the REP? As I mentioned, frameworks are also related to or have constructs which need to be measured. And another evolving area, I think critically important one, is to develop pragmatic, practical, but still valid measures of implementation, particularly in the left-hand column, and this is an important issue to differentiate an implementation outcome, which again is the process or the how. Things like, is it accepted, is it adopted, is it viewed as appropriate, particularly what are the costs? Are the costs reasonable for that setting? How feasible is it, penetration or what we call reach, and can it be sustained with the actual, as you see, the service outcomes that Enola Proctor and colleagues have talked about, and finally the client outcomes, or the bottom line over there, all the way to the best of all worlds, producing a public health or a population outcome. Just briefly here, and you'll hear a lot more about these, are funding announcements. By far the most commonly used, and one provides the greatest amount of funding in D&I research, is the PAR referenced at the top, which, as you can see, now has 18 different centers or institutes at NIH and offices playing, including like OBSSR there. So now I'm going to turn to hopefully share some of the really exciting cutting-edge opportunities for you to think about D&I research, and I'm sure many of your own projects fit nicely into these. But where is the future cancer prevention and control, and how can D&I help it? So all these incredible, including basic T1, T2 discoveries in the various omics, how are we going to get those into practice and into learning healthcare systems? For those of you that might be focused more in primary care or healthcare settings, let's look at that first. And how does D&I relate to learning healthcare systems? The whole rage, many of you I'm sure are familiar with, are big data and the interface of various types of digital health with electronic health records. There's a number of drivers. The context factors here are mentioned are really important. In terms of healthcare reform, in particular reimbursement issues are often underemphasized. But when you have too many things to do, things like guidelines and what you're reimbursed for, what you're held account for performance, make a pretty huge difference. I won't go over all the other things here, except to say that the notion of being able to do things more rapidly and efficiently and that align with the timeline of both healthcare and business is really critical, and one of the huge gaps that we've had. Traditional research is slow, and expensive, and often, particularly if you're studying things like technology things, by the time you do a traditional 5-year study, the intervention you're studying is out of date already. So here's an opportunity to do things differently, though. How do we get to systems that are actually learning healthcare systems that walk the talk, that aren't just sound good but don't really deliver? One thing is alignment. The second one, I've already mentioned the first bullet point, but the second one about alignment here is this something that's priority, that's critical to the system that you're partnering with? And often we say that this should be, the genesis of this should be something that the health system wants to do and maybe even approaches you, rather than something that you go begging that's a pet peeve or research area of yours, and then you go beg the system as traditionally done and say, well, can you just help me do, you only have to do it for 3 months and you only have to do it with this many patients for this study, then we'll go away, which is just a slight caricature of the way a lot of traditional research goes. But you can see many things there, and this also is an interesting evolving area of what we call improvement science. Wynne Norton, Brian Bittman, John O'Brien, others have done a lot of work in this area. But the notion is it's an interface or a sweet spot between traditional quality improvement, or QI, with implementation science that we call improvement science. Again, another evolving area which we're learning a lot, but particularly how to do things that are rapid and locally relevant, which is QI, but that also are generalizable and have solid science and use good measures behind them. A couple of graphics here that I would refer you to look up about learning healthcare systems, particularly those of you that are embedded in doing research within any kind of a healthcare system. You see most of these have a kind of a sequence, but also it's very important to realize that there are a lot of arrows back and forth, and there are reciprocal aspects to this as well. I'm going to contrast this notion in both the last slide and the next one I'm going to show you with what I call the more traditional, more linear stages of research model that many of us were trained on and still is used quite a bit in the field. This is another one of my soapbox issues, so I'll try to be brief here. But in my view, research does not proceed, or at least should not proceed linearly, namely from a basic conceptual or laboratory-based finding, to, as you can see, then to developing the intervention, often without thinking about designing for dissemination, then doing a pilot study, then doing an efficacy study, and then often, because your initial efficacy study that takes a 5-year grant isn't successful, you go do another efficacy study. Only then do you do an effectiveness study or a comparative effectiveness CER study. That takes another 5 to 10 years. Usually doesn't work. Then you recycle back, and then only at that point. And so you can see here, if you take this strict linear approach, you're not talking about 17 years. You're probably talking about 50 or 100 years to get things into practice. Some of us at least think this model is broken and doesn't work. Admittedly, it's controversial, and often that's the advice you will get from your mentors, and even, well, I won't editorialize too much here. Let me just go on, but saying I think you at least need to think about this and how can we make this more rapid and more iterative. So contrast this linear model with the next one that comes from the incredible program that the VA funds called the Quality Enhancement Research Initiative Program, where just if you can see the complexity, the interrelationship, the much more focus on the partners and the settings, the key stakeholders, from the outset, even in efficacy studies, designing for the real world, thinking about guidelines in the context. How is this going to be implemented? The provider focus, and I would say more than provider, even the multi-level focus, all the way from the organizational or even national decision makers down to the clinicians, down to citizens, patients, and community leaders there. So again, just contrast, if I can quickly go back, I think I can, to this linear model, what I call old school model, with a new learning healthcare system model that Amy Kilborn and colleagues call second generation. So second example, and from my perspective, your NIH colleagues can tell you much more than I can, but precision medicine, or I personally prefer the term precision health because I think it's broader than medicine. Many of you probably know about and should know about, if you don't, the All Over Us program, the NIH's signature involvement, particularly for cancer. It's also known, AKA, as the Cancer Moonshot. Joe Biden and others were real influential at getting funded, and is a major, major emphasis. Well, how does D&I fit in? Some of the questions at the bottom there are ways that D&I can help translate this evolving literature on omics of various types. How does clinical practice incorporate this, which is really new to a lot of practitioners, and there's not a whole lot of guidance and evidence on how to get these findings into practice. Can this be implemented in a way that it probably isn't going to work? Hardly ever do things work initially, but how can that evolve over time and adapt this important adaptation issues? What levels of training and support, or what types for what settings do you need? And how do you ensure, I think this is a critically important area, not only with genomics, but others, and I encourage you to look at some of the great work that David, Wayne Curry, and others have done on this. So in a way that this produces public health impact and improvement and does not exacerbate the critical issue of health inequities that we face. So just quickly, a really interesting thought piece that involved by both David and Wayne Curry, you can see how he spells his name there, and colleagues from a recent JAMA article, tries to integrate conceptually, and this nice figure here, precision. I'm again going to say precision health because I think things like what Alice Ammerman calls neighborhood omics are also at least as important as genomics. another editorial, sorry, with the learning healthcare system we just talked about, with implementation science that you see over there. Again, I think this is the future vision where we can go, and quite honestly, utilitarian, if you all want to be funded, I think you ought to be thinking about this sort of thing rather than just doing, you know, your own research area out there that it may be critically important, but is pretty unlikely to be funded. So I'm going to end with my last slide here, which I had a chance to interact with you, talk in more detail about some of these. Again, I refer you to the great set of readings you have. But from my perspective, the view of what's good science and what our goal should be of science changes from, I didn't put it here, but from my perspective, only to be slightly pejorative, the traditional view of science is that science is all about internal validity and studying a static, predetermined intervention under highly controlled conditions where you reduce variability and you study one outcome. Two, the issue, and again, I'm going to read the thing at the bottom, but the notion here, and one that's really important at the first, well, kind of the subpoint under the bullet point there, is to what extent is this program, this intervention implementation strategy replicable, both in similar settings and then in different settings. And I can't emphasize this enough, and this is another cutting edge. You've probably heard about the crisis of replication of findings, and probably this is even the most basic science. This is a huge issue, and it's probably even more so as you get more and more applied or real world. But I think some of the things that we've been talking about here, and a focus on the bottom paragraph there that I'm going to close with, is an important way that we can address this replication issue. But I like to close with what I call the ultimate use question, realizing that it's impossible for any one study to address all this, but over time and over a period of research, and what I think the scientific question for the next 10 years or more should be something of the framework like, what programs or policy components, not just the program per se, but the key components are most effective for producing what outcomes for which populations when implemented, and I left out a critically important thing here, implemented using what strategies, what implementation strategies for what types of persons, under what conditions, using how many resources, really underemphasized, and then importantly, the mixed methods approach to help us understand how and why do these results occur. So with that, I'm going to close. I've really enjoyed this. I hope you found a few nuggets in here. And now you can turn and ask David, Sarah, and other colleagues all of the tough questions. Thank you very much.